Thank you guys for coming bright and early, and thank you for coming for February's Grand Rounds. And today we have with us two of our physical therapists in our outpatient clinics. Michael Verdon, he went to Thomas Jefferson University, and he practices at our Washington, out in New Jersey. There is a place in New Jersey. We actually have clinics in New Jersey. And he's been practicing for many years and is an expert in Redcord. And then Alex Brown, he went to Dominican University in New York, and he practices at our Hellertown site. And they're both here to talk to us about suspension exercise for neuromuscular disorders. So without further ado, I will turn it over to them.
Thank you. Good morning, everybody. All right. What is Redcord? It's a question I'm asked every day by every patient I try to put on this, by every physician I try to convince that this is a good thing. So I'm hoping to present just my excitement about it, and we'll go from there. But suspension exercise, let's start with this. There's no financial arrangements between myself or Alex, and we work with St. Luke's, and here we go. All right. The objectives today: explain how suspension training can be utilized in clinical setting, identify significant differences between open chain, closed chain exercise, name the four main elements of neuromuscular activation treatment, which is referred as Neurac in the Redcord nomenclature, classify what falls under local versus global stabilizing muscles, and apply the concept of myofascial lines into everyday practice. All right. Redcord originated in Norway, 1991. The Neurac method has developed and evolved over the years by physical therapists. It's in use over 30 countries around the world. First published research was in 1992, and currently there's well over 175 publications. All right. Neurac is the treatment method that involves high levels of neuromuscular stimulation to restore functional movement patterns. The four main elements of Redcord and Neurac treatment is one, it's suspension exercise. It's closed chain, which makes it unsteady. We perturbate or shake the ropes, which increases the unsteadiness. We have a precise workload. We can grade this exercise specifically for the patient. And this is one concept that I think really makes this treatment approach stand out. I can work with an Olympic athlete and give them a very, very challenging workout. I can work with a very frail person and give them a very safe workout, and everybody in between. And the real big thing is it's pain-free. If it's producing pain, you're changing how the body recruits muscles and in what order. All right. So open versus closed chain exercise. Number one, with joint compression, you stimulate the articular receptors, which increases proprioceptive input to the central nervous system. Also, with multi-segmental movement, you incorporate core stability to be able to achieve the movement. All right. This facilitates, closed chain exercise facilitates the co-contraction of antagonist muscle groups, which also enhances functional stability, neuromuscular control. Everything we do on here requires the patient to control their own body weight, which makes this a very functional mode of exercise. All right. Stability proximal stability is needed for distal control. And I love this, if you fired a cannon in a canoe, not good things are going to happen to the people in the canoe, and that cannonball is not going to go very far. If you're on solid ground, you get very different results. And here I'd like to just interject. I had a patient who came in with ankle instability, and he had been through multiple sessions of physical therapy and over the years, and he was facing the point of where he might have needed a surgical stabilization of the whole ankle joint, a fusion. So he came in, and I said, all right, you're using TheraBand, you're doing open chain exercises, you're doing your standard balance exercises, and you still have an unstable ankle. So let's try Redcord. And prior to putting him on the ropes, which you'll see an example in a second, when he went to stand on the leg, immediately give out. And I worked not his ankle on Redcord, but I worked his pelvic and low back stabilizers through the hip joint. And within 10 minutes, I got him off the table, bang, straight leg, single leg stance without any issue. And I think it just illustrates when you have a solid core, your distal joints work just so much better. All right. So the objective of Neurac treatment is to get the right muscles firing at the right time in the right amount. And what we try to do is facilitate the interaction between your global movers and your local stabilizers. Your global movers being the rectus abdominis, erector spinae, quadratus lumborum, internal and external obliques. Your local stabilizers, transverse abdominis, multifidus, psoas, and the pelvic floor. The main complaint of patients coming into me with back pain and stiffness is just that. They have pain, they have stiffness. If I can facilitate those local stabilizers, transverse abdominis, multifidus, pelvic floor, and psoas, it allows and facilitates the relaxation of your global movers to be able to move and not provide what they're not really meant to do, stability, because you've got a stable core. Studies have shown that, why is low back pain particularly episodic? Once you have an episode, they start occurring in more and more frequency. And one of the big things I think with Redcord is we address the pain issue. Pain inhibits muscle activity. Pain changes recruitment patterns. Once those altered or inefficient patterns are established in the body, they're tough to break. And this is a method that we can change and get a more efficient pattern going for that patient. One of the studies that I really love, basically with Redcord, is done by Hodges that looked at this feed-forward mechanism. They had patients either with back pain, neck pain, or shoulder pain look at a wall, flash a light, and raise their arm. Normal people without back pain, shoulder pain, or neck pain, the first muscles that fire are your transverse abdominis multifidus, followed by the anterior deltoid. People with pain, the first muscle that fires is your anterior deltoid. The last muscles that fire are your stabilizers. We see it every day. You see somebody without pain raise their arm, you got a solid core. Somebody with pain goes to raise their arm, you watch their whole body compensate for that lack of stabilization. And it's really what we're able to address with this system. All right. Another study that looked at bridge exercise in 3 different environments. Normal, with your feet on the ground on a solid surface, on a physio ball, and on Redcord, or what's referred to as on a sling. And what this showed was, and here are the 3 different positions. What it showed is that you got a much, much stronger contraction in both supine and prone on the sling versus on the ball or on solid ground. So in conclusion, the sling position, the unstableness, the unsteadiness of the sling really enhanced the contraction of the stabilizing muscles. That is the whole point and the whole effort of what we're trying to do, particularly with pain patients. That's my point.
Continuing to build off of what Mike was just talking about, looking at a couple different studies now. We'll discuss a little bit about the shoulder and then a little bit at how we can treat some neck pain with Redcord. So this first study here looks at comparison of upper trap, anterior deltoid, serratus anterior, muscle activity, and a common exercise we utilize with shoulder and neck patients, push-up plus. And they compare that using stable surface and then the Redcord. If you want to take a look at the picture there, that kind of is exactly how the setup was for the serratus push-up plus. There are different variations you can utilize with that. You can make it easier, make it harder, but for that study, based on the readings, it seemed to be that's exactly how they had set them up. And you'll see that she has suspended both arms, that left leg is in the air, and then she actually lifts her right leg up too to create even more instability. And the control group, what they did, same exact thing, push up solid ground now. That back leg was just lifted, but that left leg was on the ground. Subject matter, there was 28 students, 10 male, 18 female. They had to have no shoulder pain for at least 6 months and no serious medical or surgical neurologic diseases. Push-up plus was, again, performed on the 2 different surfaces, and 5-second holds were performed, 3 repetitions each. What you'll see with this slide is that the MVIC in the activity for the EMG with the upper trap, anterior deltoid, and serratus were all clinically significantly higher than it was with the stable surface. Specifically, I look at the serratus anterior, and that's important to me is because we see that weak in a lot of patients with chronic neck pain, even acute neck pain, and shoulder pain. And then just to conclude that the push-up plus performed on slings considered more effective for muscle activity and the scapular muscles recommended for muscle re-education and functional improvement. Looking now at the effect of Neurac training in patients with chronic neck pain. This is one of the cervical spine settings that'll use in Redcord. You'll see at the top there that neck is completely supported, patient is maximally relaxed. They're supported by bungees and ropes and a combination of the two to allow for comfort and support. I think a lot of times we'll see patients come in, especially with acute neck pain, they're very, very tense. So getting them to relax can be one of the hardest things that we do. Now, I found in Redcord, I think Mike can attribute the same thing, patients instantly relax. You almost don't even have to tell them that cue to try and relax. They tend to instantly relax when they're in that position. So with this study, they looked at 20 subjects here, 10 and 10, and both received traditional forms of therapy. And then the experimental group had an additional 30 minutes 3 times a week for the sling-based exercises. With their comparison to look at for change, they looked at pain, neck disability index, short form 36 for function, and a fatigue and balance functional scales. Results found same, that the group that received the Neurac and Redcord treatment did have a clinically significant difference versus the control group in pain, function, balance, and fatigue. I often get the question is, do we treat other conditions, non-musculoskeletal? And Mike had touched on it earlier. We can see anything from, a young athlete who's 10 years old to a 9-year-old patient coming out of the acute setting who's just generalized deconditioning. And we'll treat everything in between, neuromuscular disorders, CVA. I have a patient currently who has inclusion body myositis, a disease that affects the mitochondria. She has a lot of difficulty performing just active movement through a full range. So what I'm able to do is put her on the Redcord in the different sling settings, get her now actually moving through those range of motions, which she cannot do without it. I will set her up for some just active assisted movement as well, but that's oftentimes how we can start to utilize it. I don't have any personal experience with the pediatric population, and I haven't read much research on that, so I wouldn't be able to attest to that. But as far as the neuro population, I think I've had a couple good results from patients in that population. The study, and I wanted to put in here just to give some research for a CVA population, would be they looked at trunk muscle activity and balance before and after intervention with 2 groups who had suffered a CVA. And the conclusion that they found was that there was no clinically significant difference, but that Redcord could be utilized. And I think it's a big question is, can we use this with this population? And they found that they had very similar results as exercises that we would commonly perform with that population. This whole idea of myofascia and Thomas Myers, the book Anatomy, or Myofascial Trains, is kind of one of the premises of Redcord, and we hear a lot of this term, this myofascia, and just to give a rough definition here, bundled together, inseparable nature of muscle tissue, and its accompanying web of connective tissue. So that's that whole idea of myofascia. I wanted to put in a picture in there just to kind of give people an idea of, hey, this is kind of what that looks like. And then we hear a lot about these in his book. They refer them as myofascial meridians. You might have heard of them as myofascial lines, functional lines. And the definition of that is just a connected string of myofascia or fascial structures, or an anatomy trained line. This would be an example of one of those lines. Now, it's hard to conceptualize because it's more anecdotal. There's not a lot of research on myofascial lines. But this, for instance, would be your back functional line. And you can see latissimus dorsi connected into our thoracolumbar fascia and into our opposite glute. When I pull this picture up, I like to say to whoever I'm teaching this to is, this is like our classic low back SI joint unilateral pain who comes in with that point pain right in the SI joint. We can activate that opposite lat glute to help give that stability to the entire pelvis. And oftentimes we'll utilize table exercises and then try and progress that to a functional exercise as well. Just some other pictures of the myofascial, we call them lines or meridians. The interesting story, so for me, I took the course and went through this, and I said, I don't really buy into the whole myofascial line thing. And I had some shoulder pain when I took the course for Redcord, and I couldn't move my left shoulder for some reason that day above head without getting impingement. And the instructor put me on my side. He utilized the second picture in from the left, that lateral line. And he put me on there and had me move around, got my hips engaged, got my core engaged. And I stood up, and I'm kind of like that whole, no, this isn't going to work. Move my arm pain-free completely. And that's the point I was like, oh, maybe this actually can work. And started utilizing these lines now in my treatment for back pain, neck pain, shoulder pain, and I found actually very good results. With the anatomy lines, I wanted to put some application. What do we commonly see daily? Patient population. So whether this is a outpatient orthopedic, could be inpatient. We're looking at gait a lot. I think we look at gait in every aspect of physical therapy, no matter whether orthopedics, pediatrics, acute. And we can start to see how these functional lines start to take place. So if you want to look at that left picture with the lateral line, if his posterior glute medius is not kicking in on that right side, he's going to get that collapse of that knee on the right side. He's going to get that collapse of the trunk. And then everything's going to break down below that. Mike had talked about the ankle a little bit earlier, and you could definitely see how someone with an ankle problem could have difficulty with weakness proximally. We can also look in this picture at not only the lateral line, but looking now at an oblique line and how the effect on the core and that opposite hip to shoulder, front and back, can be affected on gait, and how we can start to work on this proximally to affect someone's gait. I think we'll start to work on knee, we'll work on hip, but we won't address the core a lot of times when we see people with gait dysfunctions. And then looking a little more at a different population, at a picture here. And I thought this was a really good example because this is a young, picture. I think this was taken out of the Little League World Series. And you can see as he lands on that right foot breaks down, the knee breaks down, the hip breaks down, and then his left shoulder breaks down. And the whole entire chain breaks down. And I think that if he had that whole concept of stability core-wise at the hip, he would not be breaking down at his shoulder. So we talked a lot about the Redcord. You saw some pictures. Mike and I wanted to put a little bit of video into the presentation, just so you can kind of see, hey, what is this like? What does this look like? What does a treatment look like? All right, everybody can see that okay? Okay, so typical low back pain comes through. I'm going to start them a lot of times with what's called forward lean. And what I'm doing here, we talked a lot about the local and global stabilizers, trying to get those local stabilizers, transverse abdominis, multifidus, activated with them in a functional position. We do a great job as therapists as activating it in a supine position, but oftentimes I think we fail at trying to get that functional then. We kind of just say, oh, we get them turning it on in supine, we have them stand, we say, okay, cue your core, but we're not really doing a great job of monitoring that. So here, what I'll do is have them into a forward lean, almost like a modified plank position, engage their core, and then have them maintain that position. And what I'm doing there is just cueing her to kind of pull in her core, pull down her ribs a little bit so she gets better activation and engagement. Making sure she is getting correct activation. Now, making this a little harder now, I changed that point of where she was now from her elbows to her hands. So whole concept of physics, longer lever arm is going to be a little bit harder. And what I ever do here is just alternate arms, almost like we would in quadruped. Alternate arm lifts. Now I'm having her cue her core, alternating arm lifts side to side to get that multifidus engaged. Okay, this is just an example of, say somebody came through, and Mike and I talked a lot about this needs to be pain-free. And we want to make sure they're not getting pain, so they are getting the correct muscles activated. They're not compensating. I give her support now with bungees, and now have her perform that same exact movement. And I've had plenty of patients who come through. They have some pain with this. Maybe they can't quite activate. You're not getting what you want as far as movement. Decrease the load a little bit. Now activate. And you'll see on the top there, I'm shaking the cords a little bit. That's that whole concept of Mike and I talked about with perturbations and just getting further muscle recruitment with that. How do I commonly give this as an exercise? I'm not sure how Mike goes about it. I'll have somebody go to a kitchen countertop, go into that modified plank position, teach them how to engage the core, just like I did on the Redcord, walk that back a little bit, and now I have that for a home exercise program. This here would be the supine pelvic lift. Here you'll see she has support completely across the bottom around her hips. She has full support on the right side and none on the left. Same as we did with standing, and this is why we'll progress into this, engaging the core, having her go into a bridge position. So now she's activating, talking about those lines we discussed a couple slides ago, activating that right glute. It's tough to see in this picture, but have her pushing down with her left arm to get that opposite side lat kicking in. Adding a little bit of perturbation, vibration for that further recruitment. Now I can have her go through a few things with this. I can have her hold that position there. I can have her move left leg to the side, get a little bit of distal movement for proximal control. I can have her go into a march. It's kind of what you feel that they need. Now looking at getting that lateral line kicking in, and here she's going to be engaging her right hip abductors in a closed chain. So we talked about the whole concept of now proximal component moving on distal. We fixate that distal component and have her move. Again, just like I did with the first forward lean, I engage her core. I have her maintain that. I'm watching that maintain, so she does maintain that. Have her lift in that position and hold. I can have her drop out of that a little. I can have her engage that a little. And now working hip adductors on the left side. You could do this with someone with weak adductors. I personally do this for core activation. The adductors are tied right into your deep core musculature, so engaging them. And she's doing the same thing as she was on with the last movement, just going in hip adduction now. And now I have her in almost like a full plank position. Core engaged. This is a little more challenging than our forward lean. Support on the left, none on the right. Again, ensuring she's not doing a couple things. She's not rotating her pelvis. She's not turning hip side to side, dropping her leg at all. And making sure that she's keeping core engaged. And now I have her moving that right leg out to the side. Again, that little talk about moving that distal segment while keeping that proximal core engaged. Last piece here, this would be the prone lumbar setting. Having them fully suspended. And she's supported with bungees there, ropes at her knees. And just trying to get them relaxed. And what we're teaching here is just muscle recruitment. This is maybe the patient who comes in very, very acute back pain, even chronic back pain with this, but they have trouble, just any position really bothers them. I find that getting in this position can really help to relax them, one. Two, then engage the muscles that we want to in order to stabilize that core, start to get that lumbar spine stabilized. And all I'm really having her do here is at first hang out. And once they feel maybe more comfortable engaging, I don't see any compensation, I may have her do some movement. And now we're teaching the body, hey, it's okay to move. I can move my leg without having back pain. I can move my arm without having back pain. And then just going through again, doing a little bit of vibration. Stimulate some of those receptors and muscles. Get out of this. Okay. Are there any questions from the audience, from anyone listening in? Yes.
Sure. This was awesome. Thank you so much for presenting.
Sure.
So when you're strengthening, and I'm pretty sure based on what you were showing, if you're finding one line is having an issue, you're just focusing on that one line, right? Like you're not doing both sides, or are you just focusing on one?
I would say for me, I'm not necessarily looking at...
Question, please, from the people who are...
Sure. Yep. Question was, when we're looking at the like the forward lean movement, is that like something? Are we seeing any breakdown, and are we functioning or focusing on one of those myofascial lines and looking at that line and seeing if there's a breakdown there? For me, no, I'm looking at just the body in general movement. So I will typically go through, what does a squat look like? What is their, take a lump like the lumbar spine case. What is their forward bend, extension? What does their movement look like? And then from there, I'll start to utilize Redcord and see where the breakdowns are. And then I personally will apply the myofascial lines to the treatment versus look for a specific line to diagnose and that movement impairment. Does that answer your question? Okay.
One of the things that we didn't talk about today is that the Redcord and Neurac system has a very comprehensive evaluation approach. So like the first time I see a patient, I'm bringing them through all of the myofascial chains, all of the positions, and seeing what's strong, what's weak, and then addressing them. So you objectively can look at the quality of the movement and the strength of the movement, and how they're recruiting. And then you treat for a couple sessions, then you retest, just like what we normally do. So there is an evaluation component that's very specific. I would say I have yet to see anyone pass these myofascial chain tests at 100%. And I've worked with 3 Olympic athletes who are like killers, but you know, the criteria is so hard. Yeah.
Is there a weight limit of the patients that you can put in the Redcord?
The system itself has a weight limit of about 1,500 pounds. So I haven't met anybody yet, so no problem.
How long does it take to set up? Because I understand that the 10 factor.
At first, it's like anything, you, no pun intended, you learn the ropes. And so what happens is, for me at first, it was just getting used to, how do the ropes pull. But I think that is the longest part of it, where it does take time to set some of them up, especially that last video where the patient was fully suspended. That takes some time. Something like the supine lift, I can probably, what was basically like that bridge exercise, I can probably set that up in 30 seconds.
So that last one, how long would that take to set up?
A minute,
Oh.
a minute and a half.
Mm-hmm.
I mean, and that's a long time, but most of the setups I try over time, I've learned like how to sequence my treatment plan. So you're moving from one movement to the next with very little adjustment of the ropes. Maybe have the person lay supine, sideline the other way, then prone. And I haven't really had to move the ropes after the initial setup.
Is there a set protocol that you guys follow in terms of how many minutes you put them in during the session and how many times a week you have them there?
I think for me personally, it's patient-based, and I'll kind of maybe even within that treatment change. If I'm finding that they're almost looks too easy, I'll change the dynamic of the Redcord, or maybe I'm having them do longer hold times with different movements. There's no specific, for me at least, protocol. I try and make it as dynamic as possible based on what I'm seeing in that actual session. But it is, I would say though, you might spend 45 minutes doing 3 movements. You might do 5 or 6 in supine, 5 or 6 in prone, 5 or 6 in sideline, and that's your treatment.
I'm just going to say, from an outside perspective, I work with Alex, and I've used the Redcord a few times. I think it does an awesome job of getting someone to activate their core when they're having a difficult time doing it, not in the Redcord. So a lot of my patients, if they're having trouble activating their core with functional movement patterns, get them on the Redcord, and they really learn how to activate their TA and the multifidus, and you see a reduction in pain with function. So
I think one of the hard things too is a lot of people don't have a Redcord. So we'll talk about how do we utilize that now for home exercises. Physio balls are great. I think a physio ball does a great job at utilizing an unstable surface, some kind of Airex, Dynadisc, something to get them unstable. Next time you have a patient, instead of just doing a bridge on flat ground, get them on a ball. Try and have them alternate. If they're doing a multifidus press out, try and get them sitting on a ball. Try and get them standing on foam. Perturbate the bands. You can take the concepts of Redcord, without a Redcord, and apply it.
The one thing I'd add to that is what we've been presenting is the medical model, like patients coming in with pain, with dysfunction. The Redcord in the Neurac population in Norway, it has a concept of you move from there to an active lifestyle to using it for fitness. And there is a home unit, which I use 3 to 4 days a week in my garage, that's so very simple. It's 2 ropes hanging from a beam. And you can put yourself through a very efficient, very safe workout. And that's what I'm trying to move patients from needing me with bungee ropes and cords and everything else to, you can do this on your own. Yes.
Do you ever, is this, when you utilize Redcord, is it always just one modality, or do you intermix?
Well, that's really up to you as the therapist. You can do it as a totality and just do Redcord, or you can mix and match depending on the patient.
What do you guys do?
I mix and match most of the time.
Yeah, same. I try and look at that whole piece of maybe a painful squat. I see some breakdown in the back. I'm looking at that, and then I will have them on the Redcord, taking through some of the movements, reassess the squat, but then actually have them squat with some of the cues that I've now taught them in the Redcord. You can utilize a lot of the movements functionally with very simple squatting, step ups. It really is. Questions? Any online questions? Okay. Well, thank you everybody for coming. Thanks for listening to us.
Make sure you sign out if you're from New Jersey, and also make sure that you pick up, drop off your evaluation sheet and pick up your certificate. If you're online, make sure you email me for a quiz, and thank you very much.